All right, so this is the Yale20 lecture on COPD exacerbation. My name's Debbie Jang.
And I'm Bennett Clark.
And we'll be talking about COPD exacerbation. So the basic workflow is first the 5-minute bedside assessment. How can you quickly eyeball and triage your patient? We'll talk about a brief overview of what COPD exacerbation is. We'll go through the differential diagnosis and how you can narrow down your diagnosis to COPD, the treatment algorithms and some of the data behind that, how to structure the assessment and plan when you write up your patient. Then we'll review the take-home points at the end. So the 5-minute bedside assessment is really how can you quickly triage your patient and decide whether they're appropriate for the hospital, the ICU, or outpatient management. The things you really want to look for on a physical exam are signs of impending respiratory or ventilatory failure. You would see somebody using accessory muscles, tripoding. The classic teaching in COPD is that they have an increased expiratory phase. So they take a really deep breath in, but it takes a lot of time to get their air out past the obstruction. Some of the other signs that are potentially warning signs are if they're hypoxemic and signs of CO2 retention causing end organ damage, like altered mental status or arrhythmias. The other things you want to consider when you assess your patient is the historical data. So you want to know how bad is their dyspnea, how often are they needing to use their rescue inhalers or nebulizers at home, and a little bit about their past history. Have they ever been hospitalized for COPD? How often do they have exacerbations? And if they've ever needed to be intubated in the past. After that, you want to look at some of the laboratory findings, and we'll talk about the ABG as the most important one. So once you have all those pieces of data, your patient will be risk stratified. The ones who are in impending respiratory failure go to the ICU. The ones you want to keep a close eye on for their respiratory status go to the floor, and most can be managed at home. So the ABG is probably the most important test to get if you're concerned about a patient. The components of the ABG are the pH, the partial pressure of carbon dioxide, that of oxygen, and the concentration of bicarbonate in the arterial sample. When we talk about COPD, these patients usually have some level of chronic acidosis, and what you're looking for is whether they have an acute respiratory acidosis on top of that. The way to identify that in an ABG is in an acute process, you don't have enough time to compensate by increasing the bicarb, and you'll see that that patient will have a more acidemic sample and their pH will be lower. The important thing about the ABG is that it helps you sort of make the diagnosis of acute respiratory failure in COPD. One of the common questions as well is whether or not you can use a VBG, because ABGs can be quite painful to get. The takeaway point is that if your VBG is normal, that's a pretty good bet that your ABG is normal. But if your VBG is abnormal, you really want to get an ABG for a more accurate sense of what's going on. So here are 3 examples of interpreting an ABG in a patient with possible COPD exacerbation. The first patient has an ABG of 735, 60, 58, and 31. So this is a patient who has an elevated PCO2, 20 points above normal, but when you look at their bicarb, it's pretty markedly elevated, and their pH is pretty good on the lower end of normal. So this is somebody who chronically has respiratory acidosis and is compensated.
So in contrast, when we look at patient number 2, we see that their PCO2 is 56, but their pH has fallen to 7.32. And in addition, the serum bicarb is only 24, which suggests that in this case, the respiratory acidosis is acute.
This final patient has an ABG with a pH of 7.25, CO2 of 75, O2 of 39, and a bicarb of 30. In this case, you can see that their CO2 is markedly elevated, and their bicarb is not doing enough to compensate for this. As a result, they're quite acidemic with a pH of 7.25. And when you get to this level of acidemia with a pH less than 7.3, you start seeing end organ effects that manifest as altered mental status, arrhythmias, or respiratory depression. This patient needs to go to the ICU. Next, let's just go over a brief overview of COPD exacerbation. In the COPD patient, at a normal chronic level, they have thick bronchospastic airways, but when they get exposed to certain triggers, they can go through an exacerbation. The most common triggers are infections, bacterial or viral, allergens or pollutants, med noncompliance, as well as we'll discuss pulmonary embolism later. So when they get exposed to these triggers, they experience an exacerbation, which is defined by the GOLD criteria as a worsening in cough, either more frequent or more severe, sputum production, there can be a change in the quality of the sputum, the quantity of the sputum, or dyspnea, so worsening dyspnea or new dyspnea at rest. The treatment goals that you want to focus on for a patient in COPD exacerbation is to manage their bronchospasm, decrease the inflammation in the airways, support them so that they don't go through respiratory failure, and then treat the underlying trigger if possible. So now we'll go through the differential diagnosis and how you can think about a patient with dyspnea.
So the differential diagnosis for dyspnea is long, and there's a number of things you can ask to try to home in on whether this is due to COPD or some other cause. And Debbie's already highlighted 3 of the key features of a COPD exacerbation, and they include shortness of breath, which we're discussing right now, cough, and sputum production. Asking a patient about symptoms that are similar to the flu, like fevers, chills, and myalgias, may help you uncover that a viral illness is the trigger. Alternatively, though, you need to keep in mind that viral syndromes can be the cause of shortness of breath and flu-like symptoms on their own without underlying COPD. It's always important to ask your patients about whether they've been using their COPD medications like fluticasone salmeterol. Another important question I sometimes ask is whether their shortness of breath is relieved by rescue inhalers or rescue nebulizers like albuterol. If they do get short periods of relief from rescue inhalers, that's a sign that this may be due to reactive airways and COPD. In any patient with shortness of breath, it's always essential to obtain a detailed smoking history, and that's no exception in this case. And then it's also important to ask about comorbidities that might mimic a COPD exacerbation. So that includes asking about past medical history that could predispose the patient to coronary artery disease, including diabetes or CKD. On physical exam, things that I look for, wheezing is often present, an important sign. However, in your patient, especially with known severe COPD, in which there's no wheezing but you do see or hear absent or decreased breath sounds, that can be an important sign that the patient simply isn't moving enough air to ventilate effectively. A prolonged expiratory phase is another key sign of airways obstruction that we often see in COPD. And then simultaneously, you're also looking for signs that this shortness of breath may be associated with CHF. So this is the case where peripheral edema is very helpful. An elevated JVD is somewhat useful in that it can be a sign of left heart failure, but you also have to remember that your patients with COPD are going to have significant right heart dysfunction too because of their chronic hypoxemia. And so that elevated JVD may be a reflection of right heart dysfunction. One important thing that I check for is I always ask about orthopnea, and I test for it on my physical exam because orthopnea in particular makes me think about left-sided heart failure as a cause for the person's dyspnea.
So next we'll just run through a few presentations of dyspnea and what to consider on your differential diagnosis. So this first patient has dyspnea, but they don't really have very much cough. They may or may not have some fevers at home. They may or may not have a little bit of chest pain. When they are examined in the emergency room, they have a fever, you notice some hypoxemia, maybe some hypotension. And on exam, they might have some crackles, but not a whole lot of wheezing or anything else. So this is a patient you might want to ask yourself whether they have a pulmonary embolism. Some initial testing you can consider to rule that out or in includes D-dimers, Dopplers, and CTA imaging. We just wanted to talk a little bit more about the connection between PE and COPD because this is a pretty hot topic right now. There's definitely a connection between COPD and PE, although it's debated whether or not there's any sort of causative connection there. At the very least, those patients who come in with COPD exacerbation, not from an infection, will often have a PE up to 25% of the time. It may just be because COPD patients have risk factors for PE, but it's debated whether the PE is actually the cause of the trigger. And importantly, you want to think about PE in your patient coming in with COPD exacerbation because it's a significantly elevated mortality risk factor. The way you can suss out whether your patient has a PE is to first use the Wells criteria that helps you risk stratify your patient. Those who have low pretest probability, you can usually just get a D-dimer, and if it's negative, you can say, okay, they don't have a PE. If they have really high pretest probability, you usually just want to go straight to getting some imaging to rule out the PE. So the takeaway here is that there's some connection between PEs and COPD, and if you have a patient coming in with an exacerbation not caused by an infection, you really want to consider whether or not they have a PE that's underlying everything.
So very frequently when you're evaluating a patient with dyspnea, you're trying to decide whether or not that patient has acute decompensated heart failure. So in this slide, we have an example of a patient who comes in with dyspnea, but rather than complaining of fevers and chills and wheezing, the patient describes increasing peripheral edema, orthopnea, which is shortness of breath when they lie flat, and PND, which is paroxysms of nocturnal dyspnea, meaning they wake up frequently at night feeling short of breath, and that shortness of breath is relieved when they either sit up or stand up. On exam, this is a patient who has bibasilar crackles. You see peripheral edema, and their jugular venous pulse is elevated. One way you can evaluate for volume overload and decompensated heart failure is by checking a pro-BNP. And if that's elevated, it's a sign of increased myocardial stretch and increased filling pressures at some point in the heart. Again, patients with COPD, because they can frequently have right heart dysfunction, could also have a high pro-BNP. And some ways that I evaluate for this on my physical exam, I lay my hand over the sternum and feel for an RV heave. I also listen for tricuspid regurgitation.
This next patient comes in with dyspnea. They are complaining of chest pressure, but not wheezing or fevers. And on physical exam, they look uncomfortable, pale, diaphoretic, but they really don't have fever, they don't have wheezing or very significant lung exam. So this is a patient you want to consider ACS, and for that you would get an EKG and troponins.
All right, and then finally in this slide we have a patient who's coming in with shortness of breath, cough, and sputum production, as well as fevers and chills, and some recent sick contacts. And the most notable thing on the physical exam is that you have signs of a consolidation when you listen to the lungs and decreased breath sounds. So this is a setting in which you'd be concerned for pneumonia. A very straightforward way to start evaluating for that would be with just a plain chest x-ray.
And then if you see a patient who has dyspnea, maybe they have chest pain, but the most striking thing on their physical exam is that they have absent breath sounds on one side. You want to consider pneumothorax, and that can be easily ruled out with a chest x-ray.
So this is a slide we included because problems with the vocal folds and problems in the trachea can often masquerade and be misdiagnosed as COPD. So in our first patient, you see that the obstruction is above the vocal folds and actually outside of the chest and the neck. And classically on physical exam, this is a patient who will have stridor, which is a wheezing sound when they breathe in. One important thing to note whenever you're describing wheezing is whether there's just one tone present or whether you hear lots of different tones. The reason I mention that is because if you look at what happens in COPD when you have obstruction in multiple airways. You get multiple different tones, and this is what some people describe as musical wheezing, where you hear high-pitched tones and low-pitched tones. If you're just hearing one tone, you should think about a single obstruction in a relatively large airway. And if you hear that tone on inspiration, again, you should think of stridor. We've highlighted paradoxical vocal fold dysfunction on this slide, in part because it's frequently misdiagnosed as COPD or asthma. And this happens when the vocal folds come close together and obstruct the airway abnormally. And that can be associated both with psychiatric illnesses and with GERD. So that's an important thing to keep on your differential. One thing you'll notice with those patients is if they do need intubation, instead of having high plateau pressures that you would expect from true COPD, when they're intubated, they have relatively normal plateau pressures and come off the ventilator quite quickly. Here in the middle, we have another patient who has a large airways obstruction and perhaps would have a monophonic wheeze, but the level of the obstruction is down in the thorax. And then finally, we have our COPD patient at the end. You'll note that the obstruction is in multiple airways, and this is similar to the pathophysiology of asthma. Bronchiectasis can do something similar depending on the degree of airways obstruction that's involved with the bronchial damage.
So finally, to review, the key features that you look for in a patient that you suspect of actually having COPD exacerbation are the dyspnea, cough, and sputum production that they would report to you on history. There's not a lot of evidence to suggest that there's any one physical exam or historical finding that correlates strongly with COPD, but they have found that wheezing and smoking history are pretty good predictors that the patient has underlying COPD. So if you're able to elicit from your patient that they're wheezing at home, that they have a significant smoking history, that they're wheezing on exam when you listen to them, then the likelihood ratio that this patient has COPD is high. And if they have none of them, then they most likely don't have COPD. So this is a review slide that recaps what we just discussed. Important historical questions to ask your patient, in particular trying to elicit the 3 cardinal symptoms of a COPD exacerbation, physical exam maneuvers, and especially paying attention to the quality of the wheezing, and some suggested laboratory studies that you can consider in trying to narrow down your diagnosis. So next, let's talk about the treatment algorithms for COPD exacerbations. This is a nice schematic that gives us a way of thinking about how to stratify our treatment plan. In the white circle is the most basic level that you want to address for every patient who comes in with COPD exacerbation. In the light gray circle, those are the patients who have moderate to severe COPD, who are a little hypoxemic. And then the dark gray circle are those severe COPD patients who are going to the ICU and who are in respiratory failure and need some ventilatory support. This is an overview of some of the components we'll talk about in more detail in the next slides. So the evidence behind treatment modalities of non-invasive positive pressure ventilation, and this would include BiPAP or CPAP, show that if you are concerned about your patient with impending respiratory failure, using the BiPAP or the CPAP is very beneficial and reduces the likelihood that that person's going to need intubation. It can improve their in-hospital mortality and also shorten their hospital stay. And you can see in the graph on the left, especially as you get down to the patients who have more significant respiratory acidemia, the initiation of BiPAP or the CPAP, demonstrated by the dark line, greatly reduced the risk of intubation compared to those patients who didn't get ventilatory support. In terms of oxygen therapy, it's the classic teaching that you don't want to over-oxygenate your COPD patient, and you want to target their SpO2 between 88 to 92%. This is under the theory that if you over-oxygenate them, they would have a decreased respiratory drive and would actually cause more air trapping and hypercapnia.
So steroids are an important part of treatment of acute COPD exacerbations. And although the trial described at the top of this slide in 2003 used a 10-day course of steroids, more recent trials have shown that short durations of steroids are adequate. 5 days is generally sufficient, although you will occasionally come across patients with severe COPD who are followed closely by a pulmonologist who will sometimes require prolonged courses of steroids or tapering doses of steroids over a number of weeks. You should also know that there's an evolving literature on the use of antibiotics, first in the treatment of acute COPD exacerbations, and it's generally used when there are signs of respiratory infection, especially sputum production. Then the evolving part of the literature also looks at the use of antibiotics, including azithromycin, to help prevent COPD exacerbations in the first place, and that's an important part of the literature that's still being developed.
This is an algorithm of how to approach your antibiotic selection in a patient you suspect of having a bacterial trigger. In general, antibiotics are not used for patients who just have mild COPD exacerbation, and these are typically the ones who get managed as an outpatient. But for most of the patients who get admitted to the hospital in moderate or severe exacerbation, you want to think about antibiotics, especially if they have underlying risk factors that suggest a sick host. So if they're older, if they have significant obstruction on their PFTs, if they're somebody who has a lot of exacerbations in a year. And then the next step is you want to consider whether or not they're at risk for a pseudomonal infection. So this includes patients who have previously had pseudomonal infections or patients who are recently on antibiotics. And if you're concerned about Pseudomonas, you want to consider those antibiotics on the left side that would cover that organism. If not, you can do something a little bit more limited like moxifloxacin. The most common bacterial triggers are Haemophilus, Moraxella, and Strep pneumo. But like we mentioned, Pseudomonas is also a serious consideration and the other big player in the bacterial trigger. Finally, if you're getting something from the history about myalgias, flu-like symptoms, you might want to consider Tamiflu in the event that this patient has influenza. The last part of your treatment plan will be directed toward preventing future exacerbations. So once you've treated your acute patient, you really want to focus on preventing more exacerbations, especially because exacerbations are a huge marker of mortality within COPD. It's estimated that 14% of patients will die within 3 months of admission. A lot of these patients never go back to their baseline respiratory function. So smoking cessation is really the cornerstone of treating and preventing future COPD exacerbations. As you look at the graph on the right side, there are 3 patients here: the non-smoker, the COPD patient who quits smoking, and then the COPD patient who continues to smoke. If you continue to smoke, you're on this downward trajectory and have a very limited lifespan. The patients who quit smoking will start to level off, and their curve starts to mirror those of those patients who are non-smokers. So that really speaks to the fact that at any age and at any phase of their disease, smoking cessation still provides a mortality benefit. Other preventative measures you could suggest are pulmonary rehab to work on the physical condition of your COPD patient to help them manage their dyspnea at home, inhaler techniques so that they make sure they can deliver the drugs that they're taking to the airways. You want to make sure their patient is vaccinated against these bacterial and viral infections that would cause COPD exacerbations. And like we mentioned, azithromycin is currently under investigation as prophylaxis. So it's not widely used yet, but in some high-risk patients, taking once a day azithromycin might be beneficial in reducing COPD exacerbations. Finally, you want to look at their outpatient regimen. So they should be prescribed a short-acting bronchodilator like albuterol or ipratropium as needed. They should be prescribed long-acting maintenance medication. Typically, this is an inhaled glucocorticoid combined with a beta agonist. A couple common formulations are Advair, which is fluticasone salmeterol, or Symbicort, which is budesonide and formoterol. Finally, some patients will also have an inhaled anticholinergic on top of that. And one example of that would be tiotropium or Spiriva. So now we'll talk about the assessment and plan and what you want to include in your write-up.
So it's important whenever you're presenting or writing up a patient who's coming in with dyspnea to mention how long it's been present, because the differential diagnosis for shortness of breath that's only been present for a week is much different than the differential diagnosis for shortness of breath that's been around for months or years. And you can see in this assessment and plan that the author has clued us in as to what might be going on by mentioning both the patient's history of COPD and some statements that help us understand the severity of that COPD, specifically that the patient is on 2 liters of HOMO2 and has an FEV1 65% of predicted. They then go on to mention increased cough and sputum production and the use of accessory muscles on physical exam, and that the ABG shows an acute respiratory acidosis. So just from these 4 lines of evaluation, the author is making a very compelling story that a COPD exacerbation is present. So to the assessment and plan portion, what you see is just various bullet points that address different ways, different treatment modalities that we've mentioned. The first is non-invasive positive pressure ventilation, specifically in this case probably BiPAP, to support the patient's ventilation and to make sure that their oxygenation is okay. The next one addresses airways inflammation, and they're mentioning that they'd like to use prednisone. The next one is antibiotic use, especially in light of this patient's severe underlying disease and sputum production. And then they mention how they're going to provide acute bronchodilation with albuterol and ipratropium. And then the last 2 bullet points kind of look ahead towards preventative measures that will be important when this patient is getting ready to leave the hospital. And that includes smoking cessation, a flu vaccine, and ultimately, if the patient's able to participate, going to pulmonary rehab.
So the take-home points for this lecture are first the definition of COPD, which depends on worsening in sputum, cough, and dyspnea. The 5-minute assessment, so how do you eyeball your patient and identify whether they're in respiratory distress, how to use an ABG to risk stratify your patient. Next, the diagnosis of a COPD exacerbation, the other causes of dyspnea you want to consider on your differential and how you might go about ruling those out. The triggers of COPD are most often infection, so you want to really look for the underlying cause and treat that. And then the overall treatment plan for a COPD exacerbation relies on steroids, bronchodilators, and supporting their respiratory function. Antibiotics if they are in moderate or severe COPD exacerbation and you have a clear idea of whether or not an infection is triggering their COPD.